All right, so I have a few announcements prior to introducing to this morning's keynote speaker, um, who's coming in now. Um, the Welcome to the second day of HARC. This is astonishingly HARC 16, the 16th year that we've been doing this, which is just astonishing in my view. I can't believe the time has gone by so fast, and somehow Russell looks just as young as he did 16 years ago, but I don't. I don't know exactly why that would be. Um, this is the meeting is being co-sponsored by IHA. If people are not familiar, or if you're not members of the Solution Center, you can get communications from them for various educational opportunities and other offerings. They have other conferences as well around health literacy. The meeting is also connected to the journal, Health Literacy Research and Practice, which I have the honor to be the editor. Actually, has helped me with this as well. Thank you, Russell. And a few other small announcements. One is we really do need evaluations. You're going to get an email from the meeting, and getting your evaluations is extremely useful. Really, we do need that, and that's the way we continue to try to make this as good as it can be. Yesterday was fantastic, and I'm expecting today will be as well. A few other tiny little things. The posters are available to you. You can click on them through the website anytime. Unlike a live meeting, of course, you can't have a gin and tonic with the person next to their poster. But their emails are on there. Please feel free to email the authors, and they'd be interested, I believe, to hear your questions, concerns, or suggestions. With that, I'd like to introduce to Russell. You know, Russell is what I would regard as a health literacy recidivist. There's a group of people who, have toiled away at this for some time, but also an enthusiast, and so someone who also is interested to help grow the field and to help make sure that health communications, generally speaking, and health literacy in particular, can continue to grow in its scientific basis and its impact to improve patients' lives and health outcomes. Russell's a professor of internal medicine and pediatrics and health policy. He's also the Ingram Professor of Integrative and Population Health, the Senior Vice President for Population and Public Health at Vanderbilt University Medical Center, and serves as the Director of the Vanderbilt Institute for Medicine and Public Health and Associate Dean for Population Health Sciences. That's actually a lot. It's very impressive. Has coordinated just some superb large networks of research with over $100 million in funded research from federal sources. I know, Russell, it really has impacted your productivity in other areas. No, it hasn't. You just continue to be extremely productive all over. I guess the last thing is that I think of numeracy as part of health literacy. Russell makes a point of separating them out and keeping them separate. I'm sure he'll explain this himself. And maybe just to make sure that numeracy gets its proper due and its proper regard or honor in some respect, in whatever way. So with that, I'm going to turn it over to you, Russell. We have a situation, though, that there's not, for the keynotes, we don't have live mics to be open, so I'm going to help facilitate the Q&A with you. People can write them into the Q&A box at the bottom, or in the chat. We'll look at both.
Well, thank you, Michael, for a very kind introduction. You could have said a lot worse. And it is good to be here. I have lost a little bit of hair since we first met many years ago, while both really getting our career started in the health literacy space. And it's really been a pleasure to work in this area for the past now close to 25 years, honestly, because it is such an important area. And, I think we've learned over the years what an important social determinant of health health literacy is and how important health communication is really to improving health. Um, I'm going to show my slides in a second, but I'll just share a brief story about how I got started in this field, which was really as a resident. I trained in med peds primary care, and I was out in a community health clinic, and I saw a baby with concern for chlamydia pneumonia, which, a newborn baby had infection in the eyes. And when you see that, you worry that there's also infection in the lungs. And I gave them a prescription for at the time, erythromycin. I'm really dating myself, for those that know how to treat that, but and said, oh, take this, give it to the baby 4 times a day, and we'll see you back in 48 hours to make sure it's getting better. And they came back 48 hours later, and we realized that the medicine was supposed to be taken by mouth to treat pneumonia in the eyes, but mom was putting it in the eyes. And, it was a real lesson to me about how important good health communication and addressing health literacy was. In retrospect, it made sense for her to put the medicine straight into the eyes because that's where she saw the infection. And, because of the old paper prescription that just said, QID, PO, and we said, here, give this to the baby, and just assumed mom knew to put it by mouth. And the baby had to go down and get seen by ophthalmology and make sure their eyes were okay, which luckily they were. But that study literally opened my eyes, or that experience, to how important it is to address health literacy when communicating to patients and families about health. So I'm gonna share with you my research experience, which I said 25 years, but I really started in 2000, so bear with me. It's only been 24 years, but I am gonna pull up my slides and share my screen. And I mentioned to Michael, but I'm at the PCORI annual meeting right now, so I'm working off my laptop in my hotel room, so bear with me if I have any technical issues. So can folks see that okay?
Yep, it's full view, perfect.
Okay, great. So I am going to talk about addressing health literacy and numeracy, which I like to highlight, as Michael mentioned, as a important component of health literacy and lessons learned over the past 25 years. And so these are just disclosures, which is previous and current funding support. And I've generally still held on to the Institute of Medicine definition of health literacy, which has been out for some time, and really think about literacy as a functional skill and a host of different skills. So including reading and writing skills or print literacy, but also listening and speaking skills or oral literacy, numeracy or quantitative skills, which come up quite a lot in healthcare, as well as cultural and conceptual knowledge. And I think many of you on the Zoom today know that literacy is really much more of a functional or applied skill. So it's the ability for someone to read or be told something, to take that information in, process that information, and then act on it in an appropriate way. And I do focus a lot on numeracy issues because there is so much quantitative skills hidden in everyday communication that we have in health. So it's an important component of overall literacy that we've defined as the ability to understand and use numbers and math skills in daily life. And that includes basic calculations, but it also includes a lot of hidden math like deduction and logic skills, interpreting graphs and labels, estimating portion sizes, understanding time, and of course, probability and risk communication, which is a huge component of health communication. And many of us who go into science, we sort of liked math. That was like one of the things that pulled us into science. But we have to remember that the average American does not like math, does not have a good grasp of probability, and like Calvin in this old Calvin and Hobbes cartoon sort of always found math very intimidating. And now when they see things with numbers, they sort of break out in a cold sweat and don't want to deal with it. But there's quite a bit of hidden math in all of healthcare, not just patient provider communication, but even if you think about the recent COVID epidemic and public health, often we're communicating around math related issues, which can be so challenging for many people. And so we early in my career really did a lot of studies demonstrating how challenging it was for many Americans to understand basic health information, including understanding food labels, estimating what a normal portion size should look like if we told them what a normal portion size is, understanding over-the-counter cold and cough medicines, understanding growth charts that we often show in clinic and during well-child visits, understanding how to mix baby formula. And in all of these studies, we first of all showed that almost everyone was struggling to understand some of the literacy and numeracy concepts that were being expected of them in day-to-day care of their health. But it was particularly challenging for people with lower literacy or numeracy skills. And I think probably one of the I don't know if I'd call it the great moments of my career, but one of the moments of my career was when we did this study showing how hard it was for people to understand food labels, and it made it onto quite a bit of news shows, including I got interviewed on CNN, as you can see on the slide here, but it also went on the Colbert Report back when he had that show on the Comedy Channel, and he wagged his finger at the FDA for making food labels so hard to read. And one day I'll share the video. It's a lot of fun. But we reached out to the FDA initially, didn't hear a lot of feedback from them, and then after it got on the Colbert Report, we heard back from a lot of people. That was our best press, was getting on the Colbert Report. So this was really some good work, very simple work, but really helped demonstrate how challenging it was for people, even some people with good literacy and numeracy skills, to understand labels. And I think the other thing that we learned in this study is while you would expect people with lower literacy to often have a hard time understanding labels or acting correctly or appropriately, depending on how you define correctly, right? After reading labels, we found even some people with high literacy would get things incorrect, even because they didn't understand how to read the label, or they would come in with such strong beliefs about what they thought was right, that they thought they knew better than the label and didn't need to pay attention to the label. So, we'd show them an over-the-counter cough and cold medicine, and they'd say, well, I just do this because I know that's right. And, they had their own heuristics that sometimes would override instruction. So while we like to think, oh, it's always the patients with lower literacy that struggle, sometimes the low literacy patients actually appreciate and follow your recommendations or what's recommended on the product, whereas sometimes we found the high literacy patients actually, even though they read it, they don't believe it. And so it can be somewhat bimodal. It's not a direct linear relationship when it comes to how people actually act in their behavior. Um, and we also did this work specifically looking at diabetes. And again, this was about 15, 20 years ago. The exact way we treat diabetes has evolved since then. But we looked at hundreds of patients with both type 1 and diabetes across multiple locations and really found that many of them, even though they had been through prior diabetes education, were struggling to understand basic health tasks, like at the time, understanding their glucose meter, understanding how many carbohydrates they took in if they ate a bag of chips, understanding how to dose their insulin correctly. And again, these skills were linked to people's or associated with people's underlying literacy skills, and in particular, their underlying numeracy or math skills. And their numeracy skills were associated with their self-management performance, their sense of self-efficacy, and even their blood sugar control. So I would say this was lesson number one to share with the group in terms of lessons learned from my career, um, which, is that literacy really is a complex social determinant. Um, Typically, when we measure literacy, we measure reading and writing skills, but we have to recognize that that's really only one component of a patient's literacy or a person's literacy, and literacy is often a much more complex skill than that, and it's a very applied skill. Um, and we also have to recognize, especially when we're doing interventions, is that even if someone has good literacy skills, that doesn't always translate to improved behavior when you present them with information, because they often come in with their own subjective beliefs and approaches that can override their literacy skills. And I think, and I'll mention this a few times today, that we focus on literacy because it's something that's potentially modifiable. We can provide people with, you know, material written in plain language with reduced jargon and address cultural communication and limited English proficiency and other things. But we have to remember a lot of times when we're doing studies looking at literacy as a predictor or exposure variable, that it's often a surrogate for many other social factors that may be contributing to worse health. So, that early work really helped, though, to understand that that literacy is important, that we often had a disconnect between what we as physicians, as nurses, as pharmacists, as the public health community were communicating to our patients and what our patients could actually understand and act on. And I think many of you know this, right? Patients, after discharge from the hospital, more than half can't tell you what their principal diagnosis was in the hospital. More than half can't properly follow through on all the discharge instructions. People in some studies only remember about 20% of what's told to them in an outpatient clinic visit. So huge opportunities to improve how we communicate to patients and their families to really empower them and help them to improve their health. And so we designed a series of trials over my career to really help demonstrate that by addressing literacy and by improving health communication skills more broadly, we could help improve behavior and improve health outcomes. So this was the first study we did. This was in North Carolina during my fellowship. So this was really the early 2000s. We took over 200 patients with type 2 diabetes that was in poor control. We gave them all an initial education session with a clinical pharmacist who was also a diabetes educator. They were then randomized either to continue usual care with their primary care doctors or to get a comprehensive intervention. And that intervention included assessing people's literacy skills, providing communication in plain language, reducing jargon, using low literacy materials. But we also tried to address some other social barriers, address transportation issues, talk with people by phone, escalate therapy by phone, and help people address other barriers. At the end of and we use Teach Back, of course, where we taught things to patients. We asked them really to teach it back to us to confirm understanding. And so at the end of this study, which was a year long, we found that we were able to significantly improve blood sugar control, blood pressure control, getting people on aspirin, and modestly improve their cholesterol, although that didn't reach statistical significance if they received our comprehensive intervention compared to the control arm getting usual primary care. The interesting thing was that when we stratified out our results by literacy status, we found, and I should mention about 2/3 of our patients had less than 9th grade literacy skills in this study as measured on the realm. And when we looked, we found that among the high literacy patients, those who got our intervention, which is the left graph, did a little bit better over time. But among the low literacy patients, those who got the intervention, shown in the red line on the right side, did a lot better. And we really felt like we were taking these patients, many of whom had baseline lower literacy skills, and really helping to empower them to understand more about not just their health, but more importantly about what to do in taking care of their diabetes. And they responded accordingly and had significant improvement in their blood sugar control. So we followed this up with a second randomized trial where we really wanted to understand again this math component of health literacy, because there's so much math in diabetes. And, we wanted to know if we tried to address the literacy issues and really focus in on some of the math issues, could we help our diabetes patients do even better? So we created an educational toolkit to use when teaching patients about their diabetes. And we had certified diabetes educators who were nutritionists and nurse practitioners who used this toolkit to help their diabetes patients understand how to take care of themselves. And so, we used fifth grade reading level text, lots of pictures to help explain activities. We used color coding to help explain numbers. And we did a lot of step-by-step instructions. We took a lot of complex math skills, like, for example, figuring out how much insulin to take based on your blood sugar. And we would either use simpler prescriptions, or we would really walk them through step by step on how to do these skills. We had practice worksheets so they could demonstrate that they understood and were able to follow through. And we used, teach back approaches to really confirm understanding before people left the office. And so this study again randomized people either to usual care, which could be through primary care or through an endocrinologist for the diabetes care, or they got this intervention, which included seeing these diabetes educators and getting that additional toolkit and health communication about how to care for their diabetes. And again, we were able to show that those that got this more comprehensive health communication intervention that focused on both literacy and numeracy skills were able to more significantly improve their blood sugar control. All right, so we followed this up with yet another randomized trial. And this time, what we really wanted to understand is how should we teach our diabetes patients about nutrition, particularly our patients with type 2 diabetes. And so we took 150 patients with type 2 diabetes, and we randomized them to one of three arms. So they either had their usual care with their primary care provider or endocrinologist, and they had 3 visits on non-nutrition education. We gave them basic public health education. Or they got randomized to arm 2, where they got usual care with their usual provider for their diabetes, but also saw a registered dietitian who was also a certified diabetes educator, and they taught them how to count carbohydrate grams to help control their carbohydrate intake as part of their diabetes. Or you got randomized to an arm where the dietitian taught you to control your carbohydrates using what's called the modified plate method. And so on the left side shows what happened if you got recruited to the carb counting arm. So we would give you these worksheets. We would show you how you could read food labels to calculate your carbohydrate intake, help people understand concepts around serving size. So we did it in a literacy sensitive and numeracy sensitive manner, but we were still asking those patients to do a more complex skill because they had to, read all these labels, figure out their grams of carbs, figure out grams of carbs if they were making their own recipe or cooking from home, and so forth. Whereas the patients in the plate method is a very simple method that's been out for many years, where you basically tell people, take half your plate and make it free foods, which are generally vegetables. Take a quarter of your plate and make it protein, and then take a quarter of your plate for carbs, and don't pile the plate too high. And there's some other recommendations for bowls of food and liquids, but that's the basic premise. So a very simple approach to helping people manage their carbohydrate intake when they have diabetes. And what we found at the end of this study is that those who got certified diabetes education, first of all, shown here in the last column, did better than those who did not get certified diabetes education, showed in the control column. So getting that, trained, because we train those diabetes educators in good communication skills, plain language, and so forth, they really had improvement in their blood sugar control compared to those who didn't get a diabetes educator. When we looked at plate method versus carb counting, overall it looks pretty comparable, right? The people who got plate method versus the people who got carb counting both had improvements in their blood sugar control at 6 months. However, when we stratified out the results by people's numeracy skills, you can see in the far left that those who got the plate method did well regardless of their math skills. But among those who got the carb counting, those with high numeracy did well in improving their blood sugar control, but those with low numeracy did not do as well. So I think this really reinforces the concept that often simpler is best. And even patients with high numeracy skills may prefer simpler communication, simpler approaches to their care. A lot of this work helped to inform our diabetes guidelines. This was in 2012, but these principles have been maintained in future guidelines from the American Diabetes Association and from the American Association of Diabetes Educators, where, we really recommend that when giving diabetes education, we consider people's literacy level as well as cultural issues, equity issues, and other issues. So I think this brings us to lesson number 2, um, which, we talk a lot about doing health literacy interventions, and you can create materials that are low plain language, 5th-grade reading level, but often when you're doing an intervention, you're not just handing them the sheet to take home and read on their own. I mean, you can do that, but I think most of us would agree that that is a minimal intervention, right? Handing people educational materials usually is not very successful in and of itself to change behavior. So the interventions I have just walked through with you all involved a oral communication component where there is a provider, hopefully a trusted provider, communicating to the patient or their family. And they're not just doing low literacy skills, they're practicing other skills involved in good health communication. And so when we trained our nurse practitioners and our dietitians and our pharmacists in the interventions that I talked about, we didn't just teach them to use plain language. We taught them how to do some basic shared goal setting with some motivational interviewing techniques. We taught them to be patient-centered in their communication, to listen to patients, take in information, share it back, and to address cultural issues, to understand underlying beliefs patients may have in the communication process. So, I just think the lesson here is that often literacy and numeracy are important. They're cornerstones to patient understanding, but they're not in a vacuum. You can't just improve knowledge. You have to do stuff to help change behavior. And often that's going to include not just explaining things that in a low literacy way or a literacy sensitive way, but in addressing a lot of these other issues that are part of good health communication. All right, well, another trial. So we followed this up with another randomized trial. And this time we really wanted to see, can we take what we've learned in all of these academic studies and bring it out to the community. And we partnered with the Tennessee Department of Health, and we did a cluster randomized trial with 10 state safety net clinics in Middle Tennessee. These are clinics that serve predominantly uninsured patients. Over 90% of the patients in these clinics do not have health insurance. This is a very low socioeconomic status population that are coming to these clinics for free care. And we enrolled 400 diabetes patients, and we randomized the clinics either to use sort of standard diabetes education from the National Diabetes Education Program, or at 5 of the clinics, we trained the nurses, we trained the diabetes educators, we trained the doctors, the nurse practitioners in good communication skills, and we gave them an enhanced version of our diabetes toolkit to use in talking to the patients and helping them to improve their care. And at the end of the study, which went on for 2 years, we found that at the beginning, both groups had pretty significant improvement in their blood sugar control. And over time, maybe PRIDE, which was the communication intervention, did a little bit better early on, but really no significant difference between the two arms. So, there's a bunch of other challenges to the study, contamination issues with staff going back and forth between the two clinics, and people taking our education materials and bringing it to the control clinic, things like that. And we also had some loss to follow-up, other challenges. But honestly, we felt at the end of the study, the reason we were not more successful is really because we were only addressing one thing, which was, health literacy and numeracy and health communication. But there were a lot of other social determinants of health impacting this population when we brought it out into this very underserved population. They were dealing with a lot of food insufficiency. Many times they would get their food from like the local gas station or Walmart. Some of them were in and out of prison when they were in the study with us, in and out of jobs, family issues. And so, we need to remember when we're doing these health literacy or health communication interventions that is just one social determinant of health, but there are many other socio-ecological factors that may be going on in families' lives that could be impacting their health. And so, while health literacy and numeracy are important and can sometimes be sufficient in and of itself to improve health outcomes, we really need to think about it in this larger perspective. And are there other important social, political, economic drivers that may need to be addressed in order to really improve health? And I think as we do more and more health equity research, this is, a really important point in doing our interventions. All right. In addition to the work we did in diabetes, I also want to highlight some work we've done in pediatrics. And this is work we've done in pediatric obesity in trying to prevent overweight development in kids. And I think many of you are aware that in the United States, we have an obesity epidemic with about 2/3 or 70% of Americans probably overweight or obese, but this is also a problem in the pediatric population where up to 26% of toddlers and pre-K kids are considered overweight or obese. And we know if you're overweight at that age, you're at much higher risk to be an overweight adult and to develop cardiovascular problems later in life. So we really wanted to see, can we take these kids soon after birth and really help these parents and families in promoting healthy ways to growing in their first 2 years of life. So it's not, we didn't sell this to the community as an obesity prevention intervention. We sold it as these are things to do to help your child be healthy. We did this again as a cluster randomized trial at 4 resident clinics at 4 big academic institutions across the country. We had over 400 pediatric residents at the 4 sites, so over 200 of them at Vanderbilt and NYU got trained in health communication skills and given this toolkit to use to improve how we communicated to families about healthy living, healthy growing. And the other 2 sites focused on injury prevention as sort of an attention control. And we recruited 865 English and Spanish speaking families. About 40% were Latino. So it was a very diverse population. About 85% were on Medicaid. And we enrolled these families when the children were 2 months old and started to use these toolkits at every well child visit from 2 months old to the 2-year visit to see if we could help these kids grow more healthy. So again, in the 2 sites that got the intervention, we trained the residents in effective health communication skills, including training in plain language, decreasing jargon, cross-cultural communication, using shared goal setting and principles of motivational interviewing, using the teach back technique. And we gave them a toolkit to use at each visit where they could set 1 or 2 goals at each visit. The goals were in the toolkit. The back page of the toolkit was a place to write down the shared goal. And then in the active control sites, we trained the residents in injury prevention, and they used education materials from the American Academy of Pediatrics. So at the end of this study, which you can see on the left side for BMI Z-score, if you look at the bottom left graph, we found that over the first 18 months, the kids who got the intervention were gaining less weight than the kids who did not get the intervention. However, by the 24th month, they had regained the weight or were comparable to those that got usual care. And our primary outcome, which was the top left, was how many kids were overweight, defined as BMI greater than or equal to the 85th percentile by 2 years. And so again, you can see, we had a trend for improvement over the first 18 months, but not at 24 months. And so, we really felt like we had made some progress, and we did have some data showing things like decreased juice intake, decreased TV time, paying attention to satiety cues in feeding the babies. But we were losing these kids at 18 months. Because for those that do pediatric care, you know that well child visits happen at 2, 4, 6, 9, 12, 15, and/or 18 months. And then there's no visit for 6 months until they come back for the 24 months. And what's happening between 18 and 24 months? That's when kids are really exploding in their exposure to solid food, and including chips, fast food, processed food. They're going off to daycare. They're going to grandma's house. They're getting a lot more exposure. And so we really felt like we were losing these kids after the 18-month visit. And we thought we started too late because we started when they were 2 months old. And by then, many families maybe already stopped breastfeeding. They maybe already had a pattern of overfeeding. And we really felt if when we do this again, we need to start younger and we need to be able to follow these kids more closely after that 18-month visit. So we followed it up with another study, which we just finished, called the Greenlight Plus study. And this study now engaged the sites you see at the bottom of the screen. So a few more sites. And this time we randomized at the patient level. And we randomized either to um, uh, get the Greenlight materials, which we updated. You can see some nicer pictures here. Again, plain language, color coding. We did a lot of, red light, red light kind of messaging about what was okay and not okay, understanding portion size. We gave this to everybody in the study, whether you were in the intervention arm or the control arm. And we trained all the residents at all 6 sites in health communication skills. However, the difference was that in the intervention group, in addition to getting that standard health communication intervention of the Greenlight program, we started, I'm sorry, all of this started at birth this time, but we also added a digital intervention. So the digital intervention was very customized to the family, and they would set specific goals initially when the babies are young, every 2 weeks. The goals would spread out over time, and they could set very specific goals of things they were going to do to help support their child. And they also had access to a website, either on their phone or on a desktop, where they could track the progress of their child's weight. They could see what goals they had set and how they were doing with their goals. And this digital intervention could occur asynchronously. So it didn't require them to come into clinic. In our first study, we basically only had 7 points of contact for the 7 well-child visits. Now, with this digital intervention, we're able to connect with the families every 2 to 4 weeks and set a goal. And then they get multiple messages to check in on how they're doing with the goals. So very frequent intervention. And again, we're able to keep them engaged during that long 18 to 24-month period where we often were losing them in the prior study. So just to summarize, those in the standard arm got the usual Greenlight program that I mentioned in the last study, which was just the books and education from the residents. But those in the Greenlight Plus arm got that usual education from the residents with the paper books, but then they also got this digital component that included many, many text messaging for goal setting and a dashboard. And the primary outcome was looking at their weight trajectory, again, over 2 years. We enrolled 900 families into this study, and again, a pretty diverse population. And I cannot show you the results because it is in press and coming out in 2 weeks in JAMA. But I can tell you we had some positive results. So I think the lesson from this last study is that health communication is an iterative process. a lot of times, maybe if you're doing like cancer screening, you can do stuff with a one-time communication. But most things, particularly around behavior change, are going to require multiple moments of communication. Um, that communication maybe between, patients or families and their provider, but patients and families get their communication from many other sources these days, including other family members and social media. So we need to consider the role of digital media and asynchronous communication and focus on communication that promotes knowledge, trust, and behavior change. So, in summary, um, whoop, that's the wrong slide. Sorry about that. Hopefully, I've convinced you that health literacy is really, really important. It's sort of the cornerstone to improving patient or family understanding, but often it is just one component in addressing many socio-ecological determinants of health. We need to think about health literacy community interventions, addressing not just plain language, but also about building trust, cultural communication, issues around shared goal setting, and other approaches to help people not only improve knowledge, but move from knowledge to making behavior change that helps to improve the lives of themselves or their families. So I'll acknowledge many partners on a lot of this work. And I'm happy to take any questions in the remaining time. Thank you.
Thank you so much, Russell. It's a great tour of your tour de force, really, tour of your fantastic stuff over the years. There's a few questions that have been posted. One is just digital health literacy challenges that your team may have faced. You described this most recent one with a digital thing, and also just on your way of answering that, Lisa Sanders asked the title of the project, the paper that's going to be coming out in JAMA, so that people can look for it.
Oh, sure. I gotta pull that up off my email because I don't remember it off the top of my head. I mean, it's so first, just to let me answer the first question first. So, I think that there was a lot of concern early on about the digital divide. I think if you look at data from the Pew Foundation and others, that divide has closed a lot in the last 10 years. So, there's a lot of access to smartphones and certainly to being able to receive text messaging. We were did have to tell people that there could be, cost associated with receiving text messaging. A lot of that, again, has become less of an issue over time as, the cost of texting is sort of worked into people's phones, no matter what kind of phone or plan they get. So texting's become pretty ubiquitous. But that did keep us pretty we didn't go heavy on the smartphone side in terms of the app or dashboard. The dashboard was much more basic and you could access it online or on your phone. We focused more heavily on the messaging. And we did do this in both English and Spanish and spent a lot of time on the messages themselves and how to make the messages easy to read, but also not judgmental, very positive, very supportive. And we did, have to do some initial, when you first set people up, you've got to make sure it's working. So, there's some little work that goes on the front end, making sure people are receiving their texts. And we have not dug into this yet, but we have a lot of data about all the texts that were received and who were the group that responded and what factors might be associated with being more responsive or less responsive. So we're looking forward to digging into that over time.
And the support that people probably needed and to get
That's
going.
right.
Yeah.
That's right. And so, yeah, we often would be there with them at the beginning to help them understand and follow through before we would send them home.
Yeah.
Um,
There's
the
another question, totally different space, about training providers in plain language and maybe what you feel works in this or not, or
yeah, my gosh, I have been involved with training, you know, literally hundreds, if not thousands of providers in the last 25 years. And I don't want to like stereotype and be too judgmental, but there's definitely a lot of variation out there in people's beliefs and skills about their communication performance. And I'll definitely say like training med students, residents, they tend to be a little more receptive to learning. Training, practicing providers out in the community can be more challenging. They're very worried about being assessed, and we've done many different methods to training. We've done, simulation training, bringing them in with standardized patients. That's obviously very robust, but expensive, time consuming, and so forth. We've done videos, trigger videos, role play. So, I think a lot of the methods that you use really depend on which group you're working with, what's feasible for them. I think the most important things are it has to be a iterative process. Like a one-time teach is often not sufficient. So it's got to be an iterative process over time. And ideally, in our experience, we do ones where we come back later and do some kind of an observation in the real world setting, not observation in just a simulated setting. That
sure.
is hard to do,
Yeah.
hard to do. But, some of the studies I mentioned, we like certified the providers in their skills. We did sort of like an OSCE style checklist and made Kalamazoo consensus checklist and made sure they were actually practicing the skills. And even then, we see over time, because we did audio taping, that skills waver. So it has to be an iterative process. And people are so stretched for time. So that's why we really design these toolkits to help them with the communication. And a lot of times our patients told us, I mean, our residents or others said, I like the toolkit because it helps me walk through what to say. So it's not just for the patient, it's actually an intervention for the provider as well.
Got it. So, Russell, unfortunately, because of the virtual format, it just keeps on rolling. So we have two other rooms open now. People, if they could jump to the other rooms where we have presentations for you, hope to see you in those spots. And those people have already started to leave, Russell, to those other rooms.
Sure.
So thank you very much, Russell. I'm going to catch up with you some other time and hear about more of your great stuff. And thanks again. Have fun at the conference.
Thank you. Bye-bye.
Bye-bye.